Welcome back to the Simplify Senior Transitions podcast, the show where we explore stories and strategies that help families navigate the emotional and logistical journey of aging and senior care. Today's guest is someone whose background truly bridges the gap between medical expertise and hands-on senior advocacy. I'm joined by Cheryl Ringo, the founder and president of A Nurse in the Family based in Contra Costa County, California. Cheryl has nearly 2 decades of acute hospital experience, a master's degree in nursing, business, and health administration, and is now on a mission to support seniors and families through healthcare navigation, aging in place planning, and more. Whether your loved one is aging at home or facing a care transition, Cheryl's nurse led approach will shed light on what real advocacy looks like and why it can change everything. Let's dive in.
Welcome to the Simplify Senior Transitions podcast, where we help families navigate senior living, real estate, and everything in between. Hosted by Senior Transition Specialist Dale Corpus, this show brings you expert insights, real solutions, and stress-free strategies to make senior transitions simple. Ready to dive in? Let's go.
And we're back, everybody. Cheryl, welcome to the show today. How are you?
Good. Thank you so much for having me.
Okay, good. I want to let's just jump right into this. Cheryl, your career started with a volunteer role at a nursing home. What sparked your passion for elder care?
That's true. Originally, I'm from Pennsylvania, and my very first unofficial job was as a candy striper, and I
Wow.
was probably working 40 hours a week when I was 13. So I think that there was always this need for seniors are a vulnerable population. They have stories to tell. Their families sometimes don't visit. They are sort of lost and sort of left behind. And I think I noticed that very early on as a kid. Yeah.
Very good. Now, how did your clinical background in ER and critical care shape your perspective when working with seniors today?
Yeah. So again, I think it just translated into now I'm in ICU, I'm in the ER, and this same population of people don't have anyone advocating on their behalf. There's no preparedness, there's no planning, they're just sort of lost. And where a lot of things that happen with seniors can be preventable.
Okay.
So who is their voice and who's speaking to them and supporting them as they age?
Okay. Got it. Now, I love the name of your company, A
Yes.
Nurse in the Family. A
Yes.
couple questions around that. How did you come up with that name, and what even inspired you to start the company?
Sure. So originally the inspiration was, gosh, if I only had a nurse in the family, if I
Yeah.
only had someone to call, who am I calling with these questions? Who is going to sit with me to provide that extra education?
Hmm.
How do I know I'm making the right decision? This is so much. This is too much. So where is that extra layer of support is how the name really came about.
Okay.
Yes.
Now, your title includes healthcare advocate. What
Mhm.
does that actually mean in practice?
In practice, it is as a consultant, it is hiring someone on a third party basis to
Okay.
act on your behalf. It's in line with your goals, your beliefs, and really it's there to support you and become your voice when you maybe can no longer speak for yourself.
Okay. Now, I want to segue into questions about how advocacy works in the real world. My first question is, can you walk us through how you typically help a family when they call you?
Sure, when a family calls me, it's really a brief conversation of, is this somebody that I can help?
Hmm.
What are they experiencing right now? Everyone, each individual is so different. I say every person is like a snowflake because they're going to have different concerns, different needs, and am I the proper person to support them?
Mhm.
So that's the original call.
Okay. Now, what kinds of problems or crises are families usually facing when they come to you?
Sure. Um, I do get a lot more of those calls. It
Yeah.
is the people that have waited too long. Now my mom's in the emergency room. She fell, or they're admitted, but they had surgery 3 days ago. They did blood cultures, but they're trying to discharge us and we don't understand. And they want to send her home to my dad, but he can't take care of her. But what are we doing?
Yeah.
Can they do this? Who, there's a lot of, they call sometimes when it's more emergent and it is, I'm sitting on the phone for hours. I can't get through to my doctor, or my mom and my dad both have dementia. It's kind of getting worse. And no one has power of attorney.
Mhm.
No one, and they won't let anyone in, and they won't let anyone near them. It's things like that.
Now, do you act as a liaison between the family and the healthcare system? What does that look like?
I do. So it is so originally when someone retains me,
Mhm.
it is to meet them wherever home is, and it is for them to tell me what their concerns are, and then what I see, and then for us to come up with a plan.
Okay.
When someone works with me, or when we're working together, if they happen to go into the hospital setting,
Yeah.
whether it be um, on an emergency basis
Mhm.
for scheduled surgery, for a doctor's appointment. If it's a doctor's appointment, I want to make sure that they're very goal driven,
Yeah.
that there is a reason we're having these, there's a reason for this appointment. If it's for the hospital, then it's to make sure that isn't an appropriate discharge. Are the meds appropriate that they're being discharged on? Do they have the proper supportive measures in place for when they get home?
Mhm.
Did they schedule that first post-op appointment or that first appointment with their doctor? So people don't know. If you're not medical, you don't know what to ask for. And that's where a lot of these failures and breaks in communication happen, and then people scramble.
Got it. Now, how do you tailor your services differently for aging in place versus families who may be exploring senior living options?
Right. So aging in place, I believe, is a newer term. So we have a large number of seniors, right? So when we talk about, if I can, so
Yeah.
when we talk about, we have baby boomers that are aging, and it is 30% of people who are living alone. And every year they're saying that 12 to 15,000 people are turning 65 and older every day. And I think that's AARP statistic. Um, so aging in place is saying that we won't have the capacity to manage this many people and house them. So now we're
Mhm.
going to have to, they will have to age in place at their home. And I
Mhm.
think many people in general want to stay in the home where they've lived for 40 years, 50 years, where they've raised their kids and they were married and they have their memories. It's an environment that is familiar.
Mhm.
Where this gets hairy is that aging in place and saying, I'm going to age in place as a senior, does that mean you're going to sit there and watch TV every day for the next 10 years? Because it's not dynamic, right? It is waiting for an emergency to happen. It is waiting for something that now is going to force you to make a decision. It is not dynamic. Um, Aging in place to me, when I talk to people, is asking them questions.
Yeah.
It's preparedness. It is, if you want to stay home, what type of support system do you have in place if you were to, say, need to go to the hospital?
Mhm.
If you have a dog who's going to check on that on your pet, Who's going to check your mail?
Hmm.
Um, who is going to bring you back? So it doesn't matter. It could be a scheduled procedure. There's a lot of procedures that people have to get anesthesia for colonoscopies or different things like that. So it is, do you have planning for these pieces? Oftentimes I've worked with seniors where they started a will, they started a trust, but they never signed it. And now they're 80 plus years old. There was a gentleman who was over 100 who didn't have a mortuary on file. So it's really systematically now coming in and saying, if you want to do this, how do we do it in a systematic way that supports you, where now you can also have those good outcomes? So it is looking at the will, the trust. Do you have a power of attorney? Power of attorneys sometimes is the spouse, and then maybe, how competent are they at this point when they're older? Um, I had a person who was power of attorney for her sister, but she's 10 years older.
Hmm.
What happens if something happens to you when your sister is incredibly fragile and you've been managing?
Hmm.
So, um, all I'm saying is that the aging in place is a great concept. I would like for people to understand how important it is to be proactive in getting a lot of these pieces together, and that it's not just blinders. Let me alone. I'm fine. I'm going to age in place and I am fine until something happens. And I think that we have more seniors that say, I'm fine. Don't talk to me. I'm fine. I'm aging in place. I don't need anything until something happens.
Yeah.
And what that does then is it puts a lot of stress on the family, the kids who may have jobs and have children of their own, the sandwich generation.
Right.
They're not medical, to now have an emergent situation. And if you have seniors out there who don't want to deal with it, um, what are you leaving? You're kind of like, let someone else deal with it mentality. So what I'm trying to do is for the seniors who say, I did not know that there was a consultant out there who would sit with me, who I could have on retainer if something were to happen, then they know that they can call. Um, when it comes to senior living options,
Hmm.
um, you know, I would say this is sort of twofold. I'm not a senior living specialist. I don't place people. I can find someone to place that person. Where I can come in is if the family is concerned, say dad is falling,
Hmm.
who's managing him, it's best to put him in a care facility in some sort of assisted living or independent living, and he doesn't want to go. He doesn't necessarily maybe have to go. I would be able to be brought into that situation and then determine if he's falling, why. Can the home be modified? Are we looking at the medications? Are we hearing his concerns? Is there a plan that we can implement to make him successful for the next months coming up? Or after the evaluation, is it really safer for him to go to an assisted living? So it's basically hiring, again, a consultant to really independently third party say, this is what I see. These are some of the things. And now if we implement these things, can he safely be here? Or does he continue to fail? And now does he need placement?
Got it. One question I forgot to ask you in the beginning about your business is, what territories do you cover? I know we got different people listening in all parts of the Bay Area, let alone all of other parts of California. Yeah,
Yeah.
what's your territory?
So I am a new business,
Mhm.
but my goal here is to still stay small. It is
Yeah.
to still stay boutique. It is to be when someone calls that they're getting me or they're getting a nurse, but it is us. and we know who you are. So originally I started this to serve Contra Costa. There are things that I can do remote. I have helped someone who says, my dad is 90. The urologist has 3 different options to perform these different techniques due to his prostate.
Yeah.
How do we know what the best option is? I can act as a consultant and help people and provide that extra education because the hospitals don't, right? The hospitals are there for really an acute issue, right? You fall, you go to the hospital. You have a stroke, you go to the hospital. You have stomach pain, you need surgery, you get admitted, you're in the hospital. But the whole goal to the hospital is it's a volume issue. The more people we can see, the faster we can see them, the more money we can make.
Yeah.
The hospital is not there to talk about your family dynamics, come up with any sustainable plan. They are not there on a comprehensive level to get all of these pieces in place. And we have a generation of people, this silent generation, who never talked to their kids, who never said what they wanted. They just it'll be figured out.
Yeah.
The hospital doesn't want that. That level of support and education and navigation, you're not going to get that. And there is a lot of faith in God and faith in Kaiser. It's okay. It'll be worked out. When truly that's not really in your best interest when it comes to how do I age safely? How do I have conversations with my kids? How do I do this in a proactive manner that maybe extends my life, my quality of life? It allows my kids to feel safe and give them peace of mind. So it's definitely a mind shift.
Yeah.
And I do have clients that do want this. They know my kids are still, I didn't know anything at 30. I want my kids to be my kids. I want to hire a professional.
Yeah. Got it. Now, I want to dive a little bit deeper into aging in place. What's your philosophy on helping seniors age safely at home?
I believe, so my philosophy is that seniors should be able to maximize their independence for as long as possible.
Okay.
How do they do that in a safe manner? How do they do that but I guess being able to do that with dignity, being able to do that with autonomy, preserving their independence. It is one thing I think I want to bring into this is that when I come in, it is to not, I think one of the fears is that if someone was to have me come, that it's almost like a takeover, so to speak. Like, I don't want to let this person in my house because they will see X, Y, and Z and make me leave. But the philosophy is, how do I support you? And how do I become a part of the team? And how does this become collaborative that you can now maintain the independence that you so much are trying to hold on to? Because I think, again, you have 2 different sets of aging seniors. You have ones that say, I need the help. And then you have ones that are just really so afraid they may know that they're having difficulties and they don't want their kids to make decisions and put them in homes. And they don't, if I have somebody come into where I live, that they're going to tell me I have to leave.
Yeah.
Versus, let me hear your concerns. Let me try to help implement things to keep you at home safely if this is where you want to be. So it is fostering independence. It's advocating on their behalf. It's wanting them to stay autonomous for as long as possible.
Perfect. Now, What kind of home assessments do you conduct?
So this one to me is important because it's quite interesting. Um, and this is one of the differentiating factors for me.
Yeah.
There are home care agencies that will do at start of care a home assessment. So people will say, "Oh, I don't need a nurse consultant or a a nurse care manager. I don't need that because I have home care coming in, and they're going to do like a fall assessment and for safety, the part of me signing up with them." So they may come into the home and say, "Oh, we need more lighting. You can move the carpets. Oh, these chairs are on wheels." And it is, it is limited potentially, right?
Right.
In the amount of information you get. For me specifically, having been a nurse, like in the hospital, I am looking at, from a clinical perspective, how you move,
Mm-hmm.
how you talk.
Mm-hmm.
I am looking at not only the home, I'm looking at the medications because there's two different types of falls. It could
Mm-hmm.
be a trip and fall. It could be a silly, I just tripped.
Mm-hmm.
Or is it weakness? And is that weakness related to being older?
Yeah.
Or is it related to medication?
Mm.
And what the differentiating factor here is that it's not coming in to put pills in boxes, but it's to make sure that the pills are appropriate,
Mm-hmm.
that this is not something that should have been stopped, that this is not, there's two different medications that do similar things.
Mm-hmm.
So someone could have had surgery and been on an aspirin and they call them like PPIs. So like a Protonix or a Pepcid or something. But that was after surgery. Why are we still taking it?
Mm-hmm.
The more medications we take, the more issues we have down the line. And sometimes it's related to falls.
Mm.
If your doctor prescribed a blood pressure medicine and then another one, and then another one, and now you're on 3 or 4, why are you on 3 and 4? Because 1 and 2 weren't working. Why are you still taking 1 and 2 then? So again, it's a personalized audit of really fishboning or really getting down to the core reason of if you're falling, why, if something's happening, why, um, how do I keep you in your home as long as possible, but you don't have a cardiologist and you're 80 years old? So it's really looking for gaps
Mm-hmm.
in how I can support. So it's much more comprehensive when you have someone who has that clinical background to really give you sort of best case scenario on really what we're looking at.
Now, what role does coordination with home care, hospice, or DME providers play in your work?
Yeah, so I am the coordinator.
Mm-hmm.
If so with the client, if they're experiencing weakness, we can get an order to have physical therapy come in. If they need to go from a cane to a walker, I can get that ordered. So I am there to now start facilitating those pieces so the senior doesn't have to or their family doesn't have to. Um, I can start to connect. If home care or if there is something that is, um, there's progression,
Mm-hmm.
maybe from staying at home or choosing a hospice, I can give them the resources and provide them with a couple options. I already have the network and, we have a large, I don't know if people know this, but there is a large group of businesses focused on seniors. And a lot of us already know each other. So now I work with you, but I can provide you with a couple of resources because the work's already been done.
Now, are there tools or tech that you could recommend to make aging in place safer or more sustainable?
Yes. So there are two websites that I wanted to bring up for today's meeting.
Mhm.
The one is navigatingsolo.com, and there is a podcast associated with that. There is education, and it is a plethora of information that
Okay.
this woman has on her site. So I would say if you are feeling like you are navigating life alone
Mhm.
and you need some sort of support, right? That you're not the only one out there doing this,
Mhm.
that is a good website to refer to. The other one is the Care Partner
Mhm.
Project.org. And that website is so good because it talks about preparedness, what questions you can ask your doctor. What should I pack for if I need to go to the emergency room? Um, the difference maybe between palliative care and hospice or
Mhm.
whatever it is, it gives you resources that you can now have something to refer to.
Now I want to segue into medical system navigation and crisis management. My first question in this area is that I know one of your strengths is helping families navigate complex medical systems. What are some examples of how you've helped?
Sure. So again, I think it is understanding the person
Hmm.
and what their goals are. So I have a client right now that has a terminal diagnosis,
Hmm.
and the goal here is right now, I have to meet her where she's at.
Yeah.
But as things progress, having the conversation with what are those stages, and again, preparing
Hmm.
with if it is coming home or what can I manage at home versus what maybe needs to be managed at
Hmm.
a skilled nursing, or when do we bring on hospice, or how does palliative care come into play. So it is taking the confusion out and being able to sit and provide them with resources and different scenarios or situations that may happen
Hmm.
over the next couple days, weeks, or months as things progress, but also knowing what the person wants. So if anything happens outside of the plan, it was still communicated early on, and now we go with that plan.
Got it. Now, do you attend doctor appointments or hospital visits with clients?
I do. I can do as much or as little as people want me to, but I can. The goal for doctor's visits is to make them as goal driven as possible. The average time in an office visit with the doctor is 7.5 minutes. So you have someone who has some cognitive decline, has some hearing issues, has some vision issues, and now we're going to put them in front of a professional who says, "Hi, how are you doing? You're doing great. Okay, bye." Versus making sure that these are two maybe topics of concern. These are things that I hear from you. And now we can make sure that that is a goal driven visit. These are two things we want to talk about today.
Mm.
One of the things that I teach people is seniors is to make like on your calendar, if you're a little dizzy, January 1st, or say write down you're a little dizzy on this January 2nd. How do you feel? January 3rd, how do you feel? And you continually do that until you can say, "Oh, gosh, there was a few times I was there's a lot of dizzies on here."
Mm.
Because what happens with our seniors is that it becomes the norm,
Mm.
right? Because now different things don't go away
Mm.
like they used to, right? The
Right.
knee pain or some of the, gosh, it just doesn't go away. And now we've learned to live with it. But if that knee pain is the source of the fall, or if this dizziness now is a precursor to maybe having a stroke,
Hmm.
then it is important to, if they keep a log, to say, there's many times over the last 6 months that there was a lot of times I was dizzy here.
Yeah.
Now you can say, well, what have we done? Right now it gives your doctor specifics. Let's get an ultrasound of your carotid arteries. Right? So it like, now it's goal driven. Now it'll move your healthcare forward. So I like to sit with people and either I can attend or I can just help them along. But I will tell you that if I attend, it's a very different outcome.
Now, what are the biggest mistakes families make when trying to advocate for their loved one without support?
Yeah. So I would say I have this analogy about, like, so I'm not a mechanic,
Yeah.
and but I have to take my car to get my car serviced. And the mechanic can put my car up on the hydraulic system and he can tell me that I need oils replaced or filters changed or, you know, draining of some system. And he could show me anything. And I don't know. I'm going to have this trust that what he's telling me is the truth and that I will go that way. Um, and we do that with our cars. I just don't think we should do that in healthcare.
Yeah.
So a car is replaceable, and yet we have one parent or we have one body. So again, it is having someone on your behalf who
Mhm.
is knowledgeable in that arena, who
Mhm.
can spend the time to make sure that you are getting kind of like creme de la creme or best of the best. Now that if something were to happen, it's again, it's not in a reactive way,
Yeah.
right? It is, we are being, let's try to make this as proactive as possible.
Right. Now, how would you describe your advocacy style or bedside manner?
I would say it's warm and professional. I would say that I want to have the connections with families. I want to have that relationship with the clients, that I can help them as much as possible. So I would say a warm and professional type approach, but also a realistic approach that sometimes, certain things need to be said.
Right.
Um, and it's better to hear that sometimes from someone who's not family or not the child, but from a third party professional nurse who also now says that maybe there's some other things we need to look at. So a realist, but also I enjoy the stories and I enjoy the collaboration.
Good. Now, what are you most proud about for a nurse in the family and your team?
One, that I was a bedside nurse and I experienced burnout. And I literally got to the point where I said I can't continue in
Hmm.
this environment anymore. But what do I do with my experience and my education? And I want to give myself a little bit of props to say that um, I ventured forward.
Yeah.
And I think there's a lot of people that still stay in that burnout, and nurses in healthcare. If you have been in the healthcare system, or, sometimes people are like, gosh, they're mean. They're a little, it's heavy, and it's definitely heavy
Yeah.
since COVID. So I kind of want to take a moment to just say
Yeah.
that I'm thankful that I've done this because um, there are these gaps in care where someone like myself can come in and really just make very much of a difference. Um, so I'm proud to have done that. And but also in the ability to make that difference. The goal with this business right now, if somebody calls, it's myself, and then I also consult a pharmacist, and I have another nurse that we can consult. But the whole goal to this is to really stay small. And this is not supposed to be franchised. This is not supposed to get you know, crazy out of hand. This is really, you call, you get me, you call, I already know who you are. And now you really have a nurse in your back pocket who's going to be there to say, what does this mean? What does this test mean? Um, my mom feels like this. I just had someone say the other day that my dad has a fever, and I said, take him to the emergency room. And then the next day he was in the emergency room, and they said, I didn't know that it was sepsis, but it was like early. So my initial, they were like, but he doesn't want to go, but we don't want to go. And I understand that. But what's the flip side of not going, right? It's
Right.
harder to get infection under control. And but people, again, people don't understand the medical complexity with a lot of these decisions.
What do you wish more people understood about working with a nurse advocate?
That their outcomes would be different.
Mm,
Um, when you asked me originally about how this all came up about and how I worked in the hospital, but I also my dad was a big part of this. And I know that with my father, if he did not have me, then the way that his experience would have went
hmm
would have been very different.
Yeah.
And sometimes when we're working with our family members or loved ones or what have you, they're not the best options, right? It's like, well, do you want to go home to pass away or do you want to go to skilled nursing or
Right.
but they're still the person still has a right to choose. They have a right to still have their voice heard and they still have a right to have someone support them. Um so I would just say that being proactive even in the end will still give you just a much different result.
Yeah. Now, what's the most rewarding story you've experienced in this work?
I believe the most rewarding story would probably be the time that I spent with my father.
hmm
My father passed in December 2019, right before COVID. And I had mentioned about when you had asked about advocacy, right?
Right.
And that it's a much different experience. I was really my dad's only child, and that he was in the hospital. He had a new cancer diagnosis. So not only was it processing this new diagnosis and being there on an emotional level, but also understanding what are the next steps and what are the outcomes? What are the choices? When his choice was to go home, the hospital has case managers who will set up for DME, the
Right.
hospital bed, but someone has to be there to receive it. And I was there to get that. I was there to clean the house because then also hospice comes. And I think another gap here is that not all of these services are created equal.
Yeah.
Not every hospice offers the same level of service. They all have different strengths and
Right.
different offerings. So if the hospital and the doctor says, okay, we're going to rate for hospice, they will have a hospice person go out and consult with you.
Yeah.
But it doesn't mean that that level of service will be the best for you or in line with what you need.
Right.
So with my father specifically, it got down to where's the funeral home?
hmm
And now also, what do you want done with your ashes? And it really gets down to that detail. And I would be willing to do that for someone as well, especially when it comes to solo agers and people that their spouse passed, their kids aren't close. It is really building this intimate relationship of who do I count on when time is of the essence or when I can't speak for myself? who else is, who's really out there to help me. So
Got it. Now, here's one of my last questions. If someone's listening and thinking, I could use this kind of help, what should they do next?
they can reach out to me directly. The website is a nurseinthefamily.net.
Mm-hmm.
And the phone number is 925-477-7318.
Any last remarks, or you know what, or is there anything I should have asked you that I didn't ask yet?
I would just say I have a lot of conversations with people that know that their parents are older.
Yeah.
They know that they're home.
Yeah.
They know that they're at risk for falling, um, and nothing else. So in a lot of situations, I find that there is no plan. I had a 95-year-old person who called me and said, I don't need your services yet.
Yeah.
Yet you're still driving.
Yeah.
You're still shopping for yourself. You're still asking different people to help you with doctor's appointments and sort of grasping for straws. So my takeaway would be that we have the situation and we have all this information, but what happens now when you fall?
Right.
And what are we now doing in that situation? If that's your, if you can't go home now
Mm-hmm.
because you're 95 and fell and you're not a surgical candidate and now you can't go home,
Mm-hmm.
what does that mean for you? What is it like? What are the implications of not putting someone in place? A lot of these things when it comes to seniors, stroke, heart attack, cancers, and falls, they are preventative. And I think that would be my driving force here is that I think the CDC said something like 3 million people fall every day.
Wow.
And the rates of morbidity and mortality, like how many people just they don't have their outcomes or after they fall, they
Yeah.
break a hip. So now you're so worried about not being able to live in your home, but now you can't go back to your home.
Yeah.
And also now, you're not the daughter, you're the caretaker.
Yeah.
So what does it look like getting a consultant or an advocate in place to now give you a peace of mind to come in and be a part of a care team? To now you as a daughter are not the care coordinator. You're not the care coordinator, but now you're the daughter. How is that relationship now with your mom? Because it's not supposed to be where it's like a dictator mom. You have to go to the doctor and this and that. It's supposed to be, where are we going to lunch? Let's talk about stories. Let's look through pictures. And it's a different focus. So I would just say that I would like people to look past the situations and the problems, but really look at, if I don't do this, what is going to happen, and begin to implement something to change the outcome.
Yeah. Very nice. That's very
Yeah.
insightful. Cheryl, thank you so much for being here today and sharing your wisdom, compassion, and powerful stories. Your work truly embodies what advocacy in senior care should look like: nurse-led, heart-centered, and deeply personal.
No.
I know families listening will walk away with a better understanding of how important it is to have someone in their corner who truly understands both the healthcare system and the emotional side of aging. So it's been
Yeah.
a real pleasure to have you on the show. Thanks
Thank you.
again.
Thank you.
And for those of you watching, if your loved one is considering senior living and you need to figure out what to do with their home, let's talk. Schedule a free consultation with me by clicking on the Calendly link located in the video description box on this episode on YouTube. And you can learn more about my services at www.simplifyseniortransitions.com. Have a quick question? DM me on Instagram at SoldByDale. And if you found this interview helpful, make sure to like, subscribe, and share this video with someone who might need this information. Thanks for tuning in. Cheryl, thanks again for being on the show.
Thank you.
And I'll see you on the next episode of the Simplify Senior Transitions podcast.